All right, we are right at 5:30 and we like to start on time. So welcome everyone for joining us for our new educational webinar series brought to you by Urology Austin and Apex Cancer Care. We are here to share two really impactful topics this evening: beyond Viagra, exploring treatment options for erectile dysfunction, and Peyronie's disease, understanding the condition and available treatments. And I know this will be very informative for everyone joining. So just a little bit of housekeeping tonight. You can submit your questions throughout the webinar by utilizing your chat panel, and we'll make sure to pay attention to those throughout the presentation, but for sure we'll want to address any questions at the end. So don't hesitate to submit your questions. I want to remind everyone that this is a private webinar, so all of your information is confidential, but we definitely want to hear from you and be able to address any questions that you might have. So don't hesitate to submit those. The flow of our presentation is going to be about 45 minutes with educational information being shared by Dr. Sigalos and Dr. Osterberg. And then we'll leave some time for questions. And if we don't get to all of your questions this evening, we will definitely be following up with those post-webinar. At the very end, you will receive just a really short survey that will pop up on your screen when you close out. And we would love to hear your feedback because we want to continue to offer amazing content that is impactful for yourself and your loved ones. Well, I'd love to dive in, and I want to start with some brief introductions to our doctors this evening. Dr. Sigalos is a board-certified urologist who treats a wide range of urologic conditions. He has a particular interest in male sexual health, hormone replacement, and advanced treatment options for ED. And so we welcome Dr. Sigalos and appreciate the time he is spending this evening with us. And we also have Dr. Osterberg, who is also a board certified urologist and fellowship trained specialist in male reproductive medicine and microsurgery. He focuses on men's health, male infertility, and erectile dysfunction with a compassionate, patient-centered approach. So we welcome Dr. Osterberg, who is going to be kicking us off this evening. So I will hand it over to you.
Okay, well, great. Well, thanks, Jamie, for that kind introduction. And it's an honor to share the webinar stage with my esteemed colleague, Dr. Sigalos. And thank you to Urology Austin and Apex Cancer Care Center for really sponsoring this. I think this is an important topic, oftentimes overlooked in a cancer diagnosis or some of the other conditions that we treat. But we know that both erectile dysfunction and Peyronie's disease can really impact your quality of life, which is linked to so many things, and we'll touch on that. Jamie, if you don't mind sharing the presentation now. I'm not seeing anything quite yet.
Let's see, it's showing that I am sharing, so apologies for that.
I see it, Charles. I see the slide diving into erectile dysfunction here.
It may just be hidden on your screen somehow.
Okay, very good. All right, well, the purpose of the first part of this half of the webinar is to focus on erectile dysfunction, and I will kind of walk through this in kind of a two-stage process. The first of which is really understanding what is erectile dysfunction, and the second is how to treat it. So starting first with what is erectile dysfunction, or throughout this talk, we'll term it as ED. We define ED as the persistent inability to achieve or maintain an erection firm enough to have sexual activity. So And this could be obviously very subjective, depending on the partner and the situation. But oftentimes, patients will come in with this persistent inability to achieve or maintain the erection. And by maintain, we mean at any point in time during intimacy, does that erection go away? And if the answer is yes, then that would qualify for the definition of ED. It turns out ED is actually really prevalent. 1 in 5 Americans have it who are older than the age of 20. And we think that roughly half of men over the age of 40 experience some degree of ED. On average, this likely is underreported, but on average, we think about 40 million American men have ED. And when we think about ED, we kind of categorize it into two main subcategories. One, psychogenic, and the second is organic. And when we think about these two categories, the presenting symptoms oftentimes help us categorize which a man may fall under. So, for example, a psychogenic erectile dysfunction individual may likely present with the ED of sudden onset. They're typically healthy. They typically are younger. They have normal nocturnal erections, which happen at nighttime. And it oftentimes is situational, i.e., it can vary based on the partner. Now, if we contrast that with organic erectile dysfunction, and by organic, I mean there's an underlying root cause that is likely medical in nature, these patients often present with a gradual onset of erectile dysfunction that may happen over months to years. They're oftentimes associated with some comorbidities, and the nocturnal erections are likely minimal. And the prevalence of the erectile issues tend to be not situationally dependent, but with each act of intimacy. So let's talk a little bit about the physiology of how an erection happens. So the physiology first begins in the limbic systems of the brain, which is our arousal centers. And in these centers of the brain, that's where nitric oxide gets released. When aroused, the nerves of the penis become stimulated by these neurotransmitters, and this allows for vasodilation to occur. The muscles around the erectile chambers relax and fill with blood. By the blood filling the erectile chambers, also known as the corpora cavernosum, these compress the outflow channels of venous blood or dark blood, and that leads to a firm, rigid erection. So this is very much a arousal-based process that is rooted deep in important nerve input, as well as an important blood flow input. And we'll circle back to those two concepts as we start talking about some of the causes and or treatment options for erectile dysfunction. When we think about kind of a pie graph of how erectile dysfunction can be attributed to some of the organic causes of erectile dysfunction, the top three are vascular disease, diabetes, and medication-induced. Some common medications are beta blockers, such as metoprolol, thiazide diuretics, antidepressants. All can contribute to erectile dysfunction. And the other causes, albeit much smaller, when we think of either pelvic surgery, for example, prostatectomy or colon surgeries or trauma, neurologic causes, for example, Parkinson's disease or strokes, endocrine problems can certainly contribute to erectile dysfunction, such as low testosterone, and we'll touch on this momentarily. But in general, we like to think of the penis as an overall barometer of your health. And erectile dysfunction can be a harbinger of potentially cardiovascular disease, peripheral vascular disease, diabetes. So in any individual in particular who has undiagnosed medical history, or maybe an individual who does not seek medical care very often, if they come in with erectile dysfunction, we'll likely consider sending them to an internist or a cardiologist or a family medicine doctor to really evaluate how healthy are they. Because again, the penis is a barometer of your overall health. So let's dive a little bit deeper into some of these subgroups. So diabetes is one of the most common causes of erectile dysfunction. We think about 15 million people have diabetes, and 50% of diabetics will have some erectile dysfunction. So a huge percentage of diabetics. Of course, the worse off the sugar control is, the poorly the erections will be. So ED is more severe in men with diabetes. We know this for a fact. It is associated with a poor quality of life. And ED will occur 10 to 15 years earlier in men with diabetes. So the diabetes accelerates some of the vascular and or nerve damage to the penis, which then presents with early onset erectile dysfunction, maybe as early as 30 or 40. 70% of diabetics have some sort of nerve damage. And when we think about diabetic neuropathy, we commonly think about nerve damage in the hands or in the feet. Well, importantly, as we saw earlier, the neurovascular input is essential for an erection to happen, physiologically speaking. And if sugars are poorly controlled, that individual will have neuropathy, which will also impact the nervous input, which is so important for that first phase of the erection happening. In addition, diabetes causes endothelial dysfunction. We know that diabetics are at higher risk for cardiovascular events such as strokes and heart attacks. And a diabetic is going to have problems vasodilating the erectile chambers of the penis, which of course then lead to ED. Furthermore, a diabetic is going to be less responsive to some of our treatments for the reasons that I previously mentioned. So if anything, controlling the sugars and ensuring a hemoglobin A1C that is under 8, ideally under 7, will lead to an improved outcome both with and without interventions for erectile dysfunction. So the second most common cause of ED is heart disease or cardiovascular events. So 1 in 5 deaths in the United States today are due to some sort of heart disease or cardiovascular event. 50% have some form of cardiovascular disease, and that could be atherosclerosis in the heart, peripheral vascular disease in the lower extremities, etc. Early warning signs. So ED can oftentimes be the first sign of heart disease in roughly 70% of men. And we know that heart disease can sometimes present completely silent without the classic warning signs of chest pain with exertion. And we know that erectile dysfunction is an independent risk factor for cardiovascular event. Heart disease oftentimes will develop 2 to 3 years after erectile dysfunction sets in. So getting back to my previous statement, the penis is an overall barometer of your health, I think it really is signified here in the sense that if you are having some erection issues, may consider going to seek out evaluation of your heart with a stress test and an echocardiogram, an EKG, lipid panel, etc. When we think, actually go back one slide there, Jamie. When we think about the size of the artery that feeds the penis, the penile artery, this artery is roughly 1 to 2 millimeters in size, so extremely small. When we compare that to the coronary arteries, and these are the arteries that feed the heart, these arteries are roughly 3 to 4 millimeters in size, or almost double. And so if you have developed atherosclerosis or plaque buildup in your heart, the likelihood of having that same plaque buildup in your penile artery is quite high, as evidenced by the fact that the penile artery is 50% smaller than your coronary arteries. So again, men with ED have a 44% increased risk of a cardiovascular disease, 62% risk of a heart attack, and a 25% increased risk of death. How about low testosterone? So while testosterone is not physiologically necessary for an erection event to happen, again, the nitric oxide pathway from the limbic systems of our brain are the neurotransmitter that is involved in the initial cascade of an erection. Testosterone, however, is critically important for sex drive and libido, which in turn is intimately linked with erection issues. So While the act of having a physiologic erection is not directly tied to testosterone, it is indirectly tied through the ability to be aroused and to have some sex drive. So 4 in 10 men over the age of 45 have low testosterone, very common. It increases with age. It oftentimes is associated with a lot of the comorbidities that I already mentioned, diabetes, heart disease, obesity, etc. And signs of low testosterone are pretty common. Fatigue, loss of energy, a decrease in your muscle mass, decreased libido, hot flashes or sweats, depression, and then, of course, erectile dysfunction. So, how does low testosterone impact ED? Well, as I previously mentioned, a decreased testosterone level will impact your sex drive. Loss of sex drive or sexual arousal by low testosterone will reduce the nitric oxide transmitters in the brain, which then feed to stimulate an erection to happen. How about prostate cancer? Well, prostate cancer, as we know, is very intimately linked to erection issues. And the reason for that is because the nerves that stimulate erections are wrapped around the prostate. And these nerves may be injured during prostatectomy or prostate radiation. We think that roughly 75% of men who undergo some prostate treatment, albeit surgery or radiation, can develop erectile dysfunction in their lifetime. Up to 46% of men who had ED 1 year after prostatectomy, or 50% of men who had some form of ED after radiation. Individuals that have worse erectile dysfunction going into surgery or radiation have a much more difficult time recovering some of that erectile function back to where they were before treatment. We recently launched a penile prehabilitation and rehabilitation program at Urology Austin, where we focus on seeing patients before they start their prostate cancer treatment journey and intervene before these treatments happen so that we can optimize their erection function recovery after their intervention. And in addition to that, the rehabilitation after the treatment is critically important to ensure that the erectile chambers don't lose length or develop something called corporal fibrosis, where scar tissue can set into those erectile chambers. And this can lead to prolonged ED that is less likely to respond to recovery. So if you're somebody that is undergoing prostate cancer treatment or is thinking about undergoing prostate cancer treatment, please consider reaching out to your doctor at Urology Austin and talk about our prehab and rehabilitation programs. So let's talk a little bit about the quality of life component. So when we think about the impact that intimacy or lack thereof attributable to erectile dysfunction can have on somebody's quality of life, we know that it's directly corollary to depression, reduced self-worth and self-image. And in turn, those become a self-fulfilling prophecy or cyclic impact on the patient because the decrease of self-image or depression will likely in turn lead to persistence of the erectile dysfunction. So again, another emphasis on why it's so critically important to intervene upon ED early enough so that the patient can preserve their self-image, restore their relationship and intimacy, and reduce the risk of depression. So we're going to shift gears to the second part of the talk now, and that is some treatment options. So when we think about the physicians and or advanced practice providers who can treat erectile dysfunction, the answer is anybody can treat erectile dysfunction, whether it's your family medicine doctor, your internal medicine doctor, your general urologist, your men's health subspecialty urologist, or potentially in the case of a surgical prosthetic urologist, anybody in this wheelhouse can treat ED. Now, there are some accreditation bodies within the United States that oversee advanced training in these areas. So you may consider looking for somebody that is affiliated with one of these three organizations here: the Society for Urologic Prosthetic Surgeons, the Society of Genitourinary Reconstructive Surgeons, or the Sexual Medicine Society of North America. So these three accrediting bodies provide the highest level of evidence and training for individuals to ensure that the physician is up to speed in terms of the latest and greatest treatment options for ED. When we think about treatment options for ED, we oftentimes first talk about lifestyle modification. And arguably, this is the most important thing that we can advocate for, because if our patients are not hand in hand with us in this journey, and they're not willing to improve their diabetes or improve their blood pressure, arguably, a lot of the treatment options that we give may be less effective or ultimately may fail. So what are some things that you can do to improve the chance of restoring your erections? Well, weight loss, smoking cessation is critically important. Eating a healthy diet, reducing your alcohol intake, managing stress, and ensuring at least 6 to 8 hours of high quality sleep every single day. In addition, psychological counseling. So as I mentioned in one of our first slides, there's a strong or a large portion of men that have something called psychogenic erectile dysfunction. And these individuals are likely going to benefit from cognitive behavioral therapy, sex therapy, and oftentimes these psychological counselings can occur in conjunction with treatment for ED. So in addition to some of the traditional treatment options, psychological counseling goes hand in hand with some of the things that we can offer in the urology setting. So this slide really just highlights at a high level view some of our treatment options. When we think about kind of this continuum from the left side to the right side of the screen, we start first with oral medications and shockwave therapy, and then we move on to vacuum pumps, and then more invasive would be injection therapy, and then the most invasive would be a penile implant. And think of this as a continuum, and patients can kind of jump from left to right. And at any point in time, they can make a decision that either whatever they're working on is just not sufficing, and they need to advance to the next level or potentially to the last level, being a penile implant surgery. So when we think about oral PDE5 inhibitors, and this stands for phosphodiesterase 5, and this is the general terminology for Viagra, Levitra, Cialis, Staxin, etc. And there's quite a few of these on the market now. These medications all work to increase blood flow in the penis. They improve the ability to get the erection, and they improve the ability to maintain the erection after the drug is taken. But the important thing to note with all of these medications is that it does require sexual stimulation or arousal in order to get that neurotransmitter pathway flowing with nitric oxide to stimulate the vasodilation necessary. Typically, we recommend taking these medications within, roughly 1 hour for sexual activity. They typically work within 4 hours of taking them. Cialis or tadalafil tends to have the longest half-life of all these medications and can work for up to 36 hours. Typically, we recommend not taking these more than once a day. And some of the medications can be affected by food. In particular, sildenafil does tend to be reduced absorption when taken with a fatty meal. But these medications are only roughly 50 to 80% effective in cases, and half of men with erectile dysfunction after prostate cancer surgery stop taking pills because they get frustrated or decide to move on to something else. So men with diabetes are roughly 1.5 to 2 times more likely to move on to other treatments, again, for the reasons I previously mentioned. Common side effects include facial flushing, headaches, stuffy nose. You cannot take these medications with any nitroglycerin-based products. And if you do have a cardiac history, you must ensure that your heart is healthy enough to take these medications. Shockwave therapy is something that has come on to the kind of scene within the last few years. This device is non-invasive. It delivers a low-intensity acoustic sound wave to the erectile tissue. And the idea is that it helps promote new blood vessel formation. It enhances the endothelial function, or those are the cells that are responsible for new blood vessel growth. It may help regenerate nerve function. In general, this is best served for individuals with mild to moderate erectile dysfunction due to a blood flow issue. It is best in those who do not respond as well as they'd like to the oral medications that we previously talked about. In general, these treatments are given over the course of 6 sessions, roughly 20 minutes per session. And patients like Shockwave because it's painless, quick, there's no anesthesia, side effects are extremely rare, and it's non-invasive approach. So again, this is a good option for guys that are on the more mild to moderate side of their erectile dysfunction and are really just looking to augment the blood vessel endothelial function within the erectile chambers. Vacuum devices are very effective. Oftentimes, they're used in conjunction with some of the previous 2 slides, shockwave and oral medications. Think of this as a hollow plastic tube that is placed over the penis. The device is held up against the pubic bone, and via either a hand pump or a battery pump, a negative pressure suction chamber is created, and this effectively pulls blood into the erectile chambers. Once the erection is achieved, an elastic tension ring is placed at the base of the penis to help maintain the erection. Common side effects with these are decrease in the ejaculatory volume because of the constriction band, bruising, numbness, maybe some penile throbbing, and then just the need to use this device before sexual activity can really reduce one's spontaneity and may kill the mood. So patient satisfaction rates are roughly 70 to 80%. But eventually, I think due to the cumbersomeness of this device, 86% of patients ultimately do move on to seek out other therapy. Injection therapy is technically more invasive, of course, than some of the other treatments. This requires a strong, potent erectogenic medication, oftentimes referred to as trimix. This is given directly into the erectile chambers itself with a small diabetic-sized needle. Patients are taught how to do this, and then they perform it in the comfort of their own home, roughly 15 to 20 minutes before sexual activity. And 60 to 70% of men are satisfied with this. This can produce a reliable erection. And over time, patients oftentimes do report that the medication tends to become less effective. And in a large study, roughly 20% of men only continue the therapy. So the compliance rate with this does decline over time. And that's mainly due to some of the side effects, including penile pain. Scar tissue can set in the location of repeated needle injection sites. Rarely do men get the complication of what's called a priapism, and this is a prolonged erection necessitating likely a trip to the emergency room. So again, 80% of men ultimately do discontinue this, similar to the vacuum erection device, due to some of these common side effects. Last but not least is penile implant surgery. So patients may try oral medications and then decide that maybe injection therapy or vacuum pumps just aren't going to be satisfactory for them, and they may jump directly to a penile implant surgery. The vast majority of men explore some of the other options that I previously mentioned to some degree. So think of this as a hydraulic surgically implanted device. A pair of cylinders are placed in the erectile chambers, a pump is placed in the scrotum, and a reservoir is placed likely next to the bladder, hidden all on the inside. By pumping the device, saline or fluid moves through the system, and that creates a very firm, rigid erection. And there's a deflate valve that the patient would then press at the conclusion of intimacy, and that'll deflate the device. Satisfaction rates for this device are excellent. At 7 years, 94% of men are still quite satisfied that they went through with this surgery. The benefits include that this is a permanent, spontaneous, long-lasting, reproducible erection. It is completely concealed on the inside. It does not affect orgasm. Common side effects include some pain, initially, certainly during the postoperative period, and some difficulty with the device and pump and so forth. Next, we have a video, which we'll briefly show. So this is an animation of how this device works. You can see some saline is moving between the reservoir and the pump is then pumping the saline towards the cylinders. to fully expand the left and right cylinder. When the patient is complete with intimacy, he will then press the release valve that'll deflate things and force the fluid back to the reservoir. Very, very easy to use device with very high satisfaction rate. So with that, I'll turn it over to Dr. Sigalos, who is going to shift gears and talk about Peyronie's disease.
Awesome. Thanks so much. All right. So what is Peyronie's disease? It's basically some scar tissue that develops around those, Dr. Osterberg was talking about those two blood chambers. There is a spongy sheath around those chambers that develops scar tissue. Here we can see in the picture kind of what that looks like. I tell patients that their penis is made up of three main parts. It's those two blood balloons that you see there, right on top of the urethra, the tube that you pee out of. And Peyronie's disease is basically where that tissue around those two blood balloons develops that scar. And if you can imagine a balloon inflating, that scar tissue doesn't stretch very well. So the bottom part of the penis in this photo, stretches well with erection, but that top part stretches less well, and you get curvature toward where the plaque is. So again, what is Peyronie's disease? It's that scar tissue development of that stretchy sheath that surrounds the erectile tissue. What are the symptoms? So mostly people notice new or worsening penile curvature. They may have pain with erections, especially in that active phase of Peyronie's disease, which is generally defined as the first 12 months of Peyronie's disease. They may notice that there's a bump or lump on their penis that wasn't there before, and they may notice penile shortening. Again, if it's not as stretchy, you may notice that the penis seems shorter with erections. What are the causes and contributing factors? Most of the time, we consider this to be idiopathic, meaning that we just haven't figured out everything yet in medicine, and we don't exactly know why this happens to each individual person. We do know that there are some associations. There are certain genetic conditions. There's a condition in the hand called Dupuytren's contracture, where the sheath around the muscles of the hand will scar, and that will cause contractions of the hand, and that's associated with Peyronie's disease. Also, there are theories about, trauma or micro trauma causing Peyronie's disease as well. Some people know that they had an inciting event, a traumatic event for which they developed scar tissue afterward, but most people do not. We also know that there's an association with ED in general and all the things that cause ED that Dr. Osterberg mentioned, diabetes and prostatectomy and such. The prevalence, while having a bent or crooked penis, I think can be, something that people don't want to talk about. It is very prevalent, So the studies would suggest that there's somewhere, depending on the age that you're looking at, 1 to 13% of the adult male population. I would estimate that there's probably 6,000 to 120,000 men in the Austin metro area living with Peyronie's disease based on these numbers. And we do know that this disease has a real quality of life impact. 81% of people reporting emotional difficulties. I mean, roughly half the men that have been looked at with Peyronie's disease are meaningfully depressed because it really affects, your relationships and your intimacy, and that ability to have that is very important, and we really believe in that. And it causes relationship problems, and even the people's partners are less satisfied with their intimacy and their quality of life. And there is definitely this association between Peyronie's and erectile dysfunction. Although, Peyronie's typically doesn't cause erectile dysfunction. Some patients will have a plaque that is more, instead of, along a line, more C-shaped, that may cause more flaccidness distal to that plaque. And we do know that there's a strong association with 40 to 50% of men with Peyronie's disease also having some degree of erectile dysfunction as well. So non-surgical treatments for Peyronie's disease, unlike ED, there is no really effective oral medication for Peyronie's disease. I tell patients this is really a mechanical problem. There's this scarring that exists, and it's a mechanical problem, and there needs to be a mechanical solution. Unfortunately, there's no pill that will help dissolve scar tissue in your body. The only treatments that have been looked at are a few injectable agents. There are two injectable agents, intralesional interferon and intralesional verapamil, that are not FDA approved but have been used in some studies and have a variety of side effects. But really the hallmark of treatment for non-surgical for Peyronie's disease is a single FDA-approved medication called intralesional Clostridium collagenase histolyticum. It goes by a trade name that's much easier to say. That's called Xiaflex. So this intralesional collagenase, what is it? It is the only FDA-approved non-surgical treatment for Peyronie's disease. It is an enzyme that helps break down the fibers that make up the scar tissue in Peyronie's disease. It basically involves 8 in-office injections over the course of 6 months. People usually do 2 injections within a week, and then you take 6 to 8 weeks off. You do 2 injections in a week, another 7 to 8 weeks off, 2 injections a week until you've completed a course of 8 injections. This injection therapy comprises the highest level of evidence, and it's been approved for men with 30 to 90 degrees of curvature that have a palpable plaque that we feel on exam. And in the randomized controlled trials that got this medicine approved, the patient saw roughly a third reduction in curvature. So in that original study, people went from about 45 degrees to about 30 degrees in curvature with the series of 8 injections. However, what we've learned over time is that these best results are going to be seen when combining the medication, the injections, with daily gentle penile stretching and straightening exercises known as penile modeling. Now, that's all well and good, but what are the side effects? What are the things that you can expect from getting these injections? So it is very normal to have penile swelling, bruising, some pain. All of that stuff generally gets better really quickly. I'd like to tell patients when I inject them that the common story is you'll inject them in the morning, and in the afternoon or the next day you'll have a phone call about where the patient is saying oh man, this looks really swollen, but then when I see them back in 3 days for the next injection within a week, that swelling is 90% gone. The quote worst complication of these injections is something called corporal rupture, which is basically a tear in that lining around the blood balloons. And even that swelling, we know, will get better over a course of weeks instead of a course of days, and it's not something that we have to operate for. There is even emerging, back real quick. There is even emerging evidence that people that use specific traction devices, instead of doing those stretching, these traction devices can be worn for longer periods of time. And so these traction devices have shown that with the injections that people are getting even more benefit. People get about 50% benefit when using these traction devices. And one was developed by the doctors at the Mayo Clinic. You go next slide. Dr. Osterberg talked about low intensity shockwave. This is an adjunct treatment in Peyronie's disease used only for the pain associated with Peyronie's disease. There hasn't been consistent evidence to show that this decreases curvature, but for people with, significant pain related to Peyronie's disease, shockwave has been shown notably to decrease pain scores for those patients. A lot of treatment for Peyronie's disease, it does end up being surgical for those with very severe curvature or for those that do not improve on the injections. There are 3 main surgical treatments that we'll get into specifically. The first is penile plication. This is a surgery that, as we talked about before, imagine that the penis just doesn't stretch on that top side as well as the bottom side because that plaque prevents the full stretching. Basically, the penile plication involves putting sutures opposite the side of the plaque to basically scrunch that tissue together in order to straighten out the penis. So the benefits of this is that 95% of patients will have less than 10 degrees of residual curvature, meaning, for the most part, curative for all those patients. This is a permanent solution. It's done in an outpatient fashion, meaning you go home the same day from surgery after about an hour under anesthesia. It has a very low recurrence rate and a very low risk to the erectile function, and it can be used for very severe degrees of curvature. The real big consideration and the thing that I talk to every man about with regards to penile plication is that there is a sense of penile shortening that happens. We are fundamentally limiting the side opposite the plaque, how much it can stretch. And so, patients will say, hey, look, my penis was shorter than when I started this. And, in my mind, the Peyronie's disease is really what causes the shortening. We're just trying to help, straighten things out. But you do have to understand that, fundamentally what we're doing is trying to match the sides. Some people can feel a suture because we do use a permanent suture. There is a small recurrence risk. People can have bleeding, discomfort, all the normal, post-surgical things that happen that generally get better over time. Now, a lot of people that come in may be thinking, so why don't you just, cut out the plaque? So that is something that we sometimes do, and it definitely can be successful at getting the curvature corrected, and that's the procedure called a plaque excision and graft. This again is an outpatient surgery. The benefit really of this is that it maintains penile length, whereas the other one does not. And it can be used for very complex cases. However, I would say that, in real practice, most people do the plaque excision and grafting less often than penile plication because there are while it's a more complex surgery and can provide some benefits, there can be other risks. It has a higher incidence of erectile dysfunction because often we have to lift the neurovascular bundle, or the bundle of tissue that carries the nerves and the blood supply to the penis. We have to lift up, as seen in that picture, in order to cut out that scar. And so some patients may notice decreased penile sensation. The graft itself can contracture, and there are some, further surgical side effects that can happen, very rare ones that can happen, that cause death of certain tissues. But all in all, again, this is another surgical option for more complex cases, with the understanding that there might be slightly higher risks. The final surgery that we're going to assess is the same one that Dr. Osterberg discussed for ED, and that's placement of a penile implant. We can, a lot of times with the penile implant placement, do a procedure called modeling, which basically involves using the stiffness of the penile prosthesis when it's fully inflated to help model that tunicle tissue, that the tissue around that implant. We can physically model it in order to straighten out the erections. So for patients with erectile dysfunction and also curvature, placing of a penile prosthesis can be a really great solution at solving both of these problems at the same time. And also at the time of penile prosthesis placement, we can do an adjunct plaque excision or plication. And again, with the plaque excision, if you're doing that with the placement of the penile prosthesis, you don't have to worry about the side effect of erectile dysfunction because we're going to be treating that at the time. And as Dr. Osberg discussed, that's a very high satisfaction procedure. It's permanent, spontaneous. The only person that will know is that you or your partner, if you let them know. And there are side effects as any surgery. So, I think that Dr. Osterberg and I both, really care about the patients that come into our office with their quality of life, and we understand that these sexual health issues are very personal and very sensitive. And we always hope to treat you with confidentiality and respect, and want to help you guys understand this process as best as you can, and be there to answer any of your questions, and hopefully just have an honest, open conversation with you guys, because we love talking about this stuff, all day, every day, and we'd love to talk about it with you if you have further questions.
Great. Well, I think we can definitely open up for questions if anyone is on and has a question, and I can start off with some pre-questions that were submitted, but feel free to jump in the chat and submit your questions so that we can address those. And I'm going to go ahead and put up the thank you slide because we want to make sure that everyone knows you can make an appointment at urologyaustin.com, and there is a phone number 512-788-9688 where you can easily call and schedule an appointment, or schedule an appointment online. But as we're waiting for some questions, Dr. Sigalos and Dr. Osterberg, thank you so much. Here are a few. One was, when should I see a doctor about ED?
The answer is now. If you have ED, you should seek out treatment, and it doesn't necessarily have to be with a urologist. At least bring it to the attention of your primary doctor or your internist or whoever you confide in for your medical care. If you are starting to notice some early symptoms of ED, there's nothing like the present to bring up these concerns with your healthcare provider.
Another question was, if I'm a partner of someone experiencing ED, what is your advice for bringing this topic up and encouraging a visit?
You know, that's obviously challenging because, I think men innately are reluctant to see a physician and are reluctant to um, confide in their physician about a very sensitive topic. But I think in general, we are seeing that even in our older patients of a different generation, that these men are starting to feel more comfortable talking about this. And my advice to this partner of a patient experiencing ED would be just really give them the confidence that they need to come make that appointment. In fact, even come with them to the appointment. Oftentimes we do see partners together for these visits, and it's actually really important for both partners to hear about what the options are and what's available to them, and really just kind of give them the confidence that they need to show up to that appointment and tell them that there's lots of great options available and that you're standing there with them throughout this process to be by their side and kind of work through this together.
Yeah, if I could jump in, I love that question as well. Just it's really great whenever we see people and their partners with them, because partners often know the patient best and can really help and guide in that decision making that happens, and have this be really a team sport. So we love seeing the partners with the patients in the office.
Thank you for that. Another question is, what are your thoughts on some of the other pills that we see advertised on social media? Or should we be cautious about those? Just generally, what are your thoughts?
Yeah, I'll start off. I think, a lot of these companies, I think they provide a great service. I think they're expanding marketing. They're tapping into individuals that may not seek out medical care in person. They're conducting televideo or telemed appointments in order to get patients the Viagra, Cialis, Levitra that they may very well may need. But I would caution individuals to understand that these practices are really just to get you in the door. But ultimately, you do need to seek out kind of more further urologic evaluation to understand kind of the underlying causes of your erectile dysfunction. The online market, it's chock full with companies out there, and some of them are very reputable, some of them are not. So certainly doing your due diligence, and if you need some support in that regard, Dr. Sigalos and I are obviously here at Urology Austin to counsel you through that. I would caution patients about some of the herbal supplements or potentially some of the supplements that you may find at a gas station or maybe a vendor that is less reputable than a Hims or a Roman or a Rougette or a Blue Chew. Those products I would definitely caution patients about.
Another question is related to Peyronie's and the surgeries for Peyronie's. What does recovery typically look like?
It depends on which surgery you end up going through, but typically for the application procedure, which I would say is the most common one, typically recovery is pretty fast. It's not very painful. They're not really like big restrictions on what you can do afterward. The biggest one is generally, we say no sexual intercourse for about a month afterward, just to let all the stitches and everything really heal. But typically, from like a pain perspective, what you can do activity wise, there's nothing that you're going to do that's going to injure or make your surgery less, successful. It's usually done through either a circumcising skin incision or a circular incision or a very small linear incision on the bottom part of the penis. As far as a plaque excision and grafting, that takes a little bit more time, and the recovery and the pain and the potential bleeding risk is maybe a little bit higher in those patients. And so the recovery may be a little bit more painful. But the good thing about any of these, operations on the penis, it's mostly up to your comfort. You're not really going to necessarily worsen much things by, you know, walking around or doing things that you would normally do during a day-to-day basis. And as far as the penile implant surgery, typically, like we said before, you go home the next day, you'll see us back in the office the next day to get your catheter and drain out. And people tend to have pain for about 2 weeks, and usually about 2 weeks, they're able to do their normal daily activities without any pain, and they can start ramping up their activity at that point.
One final question here is, I'm a bit nervous coming in. I know something is not right. Any advice for someone who might be nervous in making that appointment?
Well, I think just know that you're not alone. As I showed in some of my early slides, you can see just the sheer incidence and number of men that suffer from some of these conditions. Um, it can oftentimes be a little nerve-wracking to walk in the door, but I think once you get into the exam room with any of our doctors, because I strongly believe that all of our doctors are extremely compassionate and are going to listen to you. But I think just take confidence in knowing that your visit with whoever you see is confidential, is really focused on allowing you to be the best version of yourself that you can be.
Yeah,
Great.
I completely agree with that. I just want to say that you know, we talk about this stuff all day, every day, and we're always doing these, um, I guess highly, sensitive exams and talking with people about these highly sensitive subjects. And so we do this job because we really enjoy that, and we understand that if you're coming in for the first time, that it's going to be the first time that you're ever experiencing that. But for us, we really want to engage you, and we want you to feel confident that you're with someone that really wants to be there with you and help you through this.
Great. Well, as we come up to the final few minutes, Dr. Sigalos and Dr. Osterberg, is there anything else that you would like to share with our audience today, or any top question you feel comes up quite a bit we should address? Otherwise, we can close out.
I'll ask Dr. Sigalos a question that I commonly get, and I'm sure some of the attendees are curious. When you see patients for implant surgery, what's been your experience with insurance coverage? What do patients, what can they expect in terms of, what might be the cost for one of these devices?
So Medicare covers the devices very well. The other private insurers are hit or miss. Blue Cross Blue Shield, it tends to be a lot more miss than the other ones. But yeah, our surgery schedulers who do this a lot are very used to running quotes for patients and reaching out and trying to figure out what your out-of-pocket costs are going to be. A lot of that has to do with what your deductible is that year and whether or not you've hit it already and those sort of things. So the coverage for the private payers is pretty variable. I don't know what's been your experience. I don't have like a fast rule for that other than Medicare pretty much always pays, and the other and Blue Cross Blue Shield it tends to be the worst of the private payers in terms of implants. But
Yeah, I think I agree. I think it really boils down to your plan exclusions. I will add that the device manufacturers, both Boston Scientific and Coloplast, have financing options available to get men, the device that they may need to restore their confidence. So, it is something that we oftentimes grapple with. I would say, probably 80% of individuals end up being covered for their device. But even if you're not covered with your insurer, there are other options available. So, obviously we talked a lot about the medical stuff today. Obviously, the financial piece is another very real and relevant part of this conversation for patients. And the good news is that commercial carriers and Medicare, like Dr. Sigalos said, will pick up the tab and cover you in most instances.
yeah, and just to touch on Peyronie's disease, generally I haven't had no issue getting patients their Peyronie's disease, either surgeries or Xiaflex or the collagenase injections covered. They're very niche insurers that maybe don't cover the collagenase, but pretty much all major insurances, including Medicare, cover the injections and the surgical procedures. I haven't had any issues with that on the Peyronie side either.
Great. Anything else that you would like to share before we close out for everyone? No.
Thanks to those people on the webinar now, and for those people who are going to watch at a later date, feel free to reach out to our offices and please schedule that appointment.
Oh, I saw one question enter the chat. Do implants replace the space that was occupied by the original chambers? So yes, the implant does does replace that space. And often I tell people before surgery that once you choose to go with an implant, if you have the implant removed for any reason, the injections and the medications will not work. A lot of times, people are choosing an implant because that's already the case, or they don't like to inject, or injecting isn't a feasible option for them. But yes, those blood chambers are replaced by the inflatable cylinders. And so that space will no longer exist once that implant is removed, if it's ever removed, in the same way as before.
Thank you for the question. Any other questions? Well, like we've already shared, thank you so much for joining tonight. Thank you, Dr. Sigalos. Thank you, Dr. Osterberg, for sharing your expertise. I know this is life-changing information. And just a reminder to everyone again, you can schedule an appointment online at urologyaustin.com or by calling the office at the number on the screen, but it's 512-788-9688. We thank you so much for your time and have a great evening. Bye.